would like to introduce Professor Dũng that will talk about the PCI of small, long, diffuse, or tortuous lesion. How could we do that? Thank you very much.
Okay, thank you for introduction from Dr. Hùng. Let me share my presentation. My presentation is not a lecture. It's a serial case report, and I hope I give some clinical case for demonstration and for your discussion. Maybe 4 or 5 cases. The case number 1, small diffuse disease, left main bifurcation, non-STEMI. The patient is very young, 43-year-old. He is the relative of our colleague, our doctor. He suddenly checked band and hospitalized, were diagnosed QMI with a non-STEMI. And this is the coronary angiogram. As you see, the distal left main disease involved to pull the ostium of the LAD and such, and the long diffuse lesion along the LAD and circumflex. When we saw coronary angiogram, I don't know how to do, so I refer the patient to the cardiac surgeon. But the cardiac surgeon refused at the first sight when they see the coronary angiogram, because they thought the vessel is very small and no location, no position for the bypass trap insert. And his family, my colleague, bring him to us again and to talk me to do something. And so what can we do and how can we do? We try to do something. We have a plan to do 2 bifurcation. The first, of course, the distal bifurcation of the distal element with the ostium of LD and circumflex. And the second, I think the diagonal might be rather big, so we try to keep the diagonal. So we do the technique to bifurcation to 2 position. You can see here, and in this picture, we already perform 2 stand in 1 stand with when we do the estimation, because we don't have exactly diameter. We have the intravascular image OCT. But the OCT in this case cannot help give me more information, because as you know, the OCT to record the clear image, we must flush blood out of the vessel. And if the vessel is very small, the catheter OCT inside, we cannot flush the blood out of, so they cannot record the image. So we do the estimation, not exactly, but maybe in the mid LD 2.5, and in the diagonal 2.5, and in the mid LD maybe the 2.75. And we go to the distal left main, and in this position we have one question: we keep the circumflex or not circumflex, and how to keep? I think if we deploy stand in the distal bifurcation, the cert maybe go away. So and how much, how diameter, and in this situation and in that time I have no experience. We use the small stand 2.25 millimeter to keep the ostium of the source, and the stand up from the left main to LD proximal segment 3. And we do the final kissing balloon. And I think the last result look okay. And we don't record the OCT before we do PCI, but we have a record the OCT after, and 1 year after that, but yesterday I looked for the OCT file, but no, I don't find. But yes, so I think that this is the last result, and with the result of the PCI, I think the cert may be bigger. But in that time when I do in a immense situation, I don't know how much the diameter, so we must try a smaller stand to keep patent. So maybe 3 posts and post 1 year. And in I don't have experience about to do the same situation in the last time, but by now I have maybe some experience. So in this case, I have one question for the expert, for the faculty, and for the panelists. In the long diffuse lesion, such as this case, we have the strategy, no stand strategy or standless strategy. And in this case, with the position in the left man, distal left man, and in the setting acute coronary syndrome, can we use no stand strategy or standless strategy? I feel I'm not confident to use the no stand strategy in this situation. Okay, the second case. The second case, one case with calcified tortuous small diffuse lesion. As you see in the right coronary artery, a very tortuous, calcified, and small diffuse lesion. And in the right, the same tortuous, calcified along the LED. What we can do? Of course, in the normal situation, we don't touch about the RCA because it's very tortuous, very small, very calcified, long lesion, and maybe not good to touch, maybe more complication. But in this case, we have planned to do the PCI to the left coronary artery. So we try to do something in the right for which the heart maybe can supply some blood flow to the left. For when we do the left, it's more safer. Wiring and body wire is surely pre-dilatation with a small balloon. And we make decision to stand in only proximal and mid of the RCA. Because in the distal of the distal RCA is very tortuous. When we do pre-dilatation with balloon or stenting, a very easy rupture. So we choose stenting only a proximal segment and a mid segment. I don't know after we do stenting for the right coronary artery, how much it can increase blood flow to the left. I don't know, but it made me feel more confident go to the left. About the left, because it's a very tortuous due to the calcification, so it must attract me. Wiring, and we do atherectomy. Can you see very tortuous, very calcified tortuous? Then we deliver the stent with the help of Gidagella. You can see Gidagella. Okay. So the last result, I think, not bad. The third case, the case number 3, tortuous in the acute setting acute STEMI, inferior STEMI, primary PCI. First, you can see the left coronary artery very tortuous, but the culprit lesion is not here. But we can predict the right coronary artery also tortuous. And this is the right, as you see, the curve and tortuous in the proximal segment, in the mid segment, and obscure in the distal segment of the RCA. And the first we are wiring a little bit difficult and pretty wide and pre-dilatation. And we try to bring the stent to the culprit lesion with the Zilla, but when the stent go, it gets stuck in the proximal segment because we see the lesion not only the culprit lesion in the second curve. They have the one lesion in the first curve and one lesion in the mid, and the third lesion is culprit lesion. So what can we do? So, and often when we do the many stent, the order of stenting is the distal stent first, and after the proximal stent. In that case, I saw the diameter of proximal and the mid and the distal distal of RCI now very different. So we made decision to stent the proximal segment first to prepare the way for the second stent go. So I deploy the stent in the first curve. After we deploy stent in the first curve, the second stent go easy, and it go direct to the culprit lesion. So the second stent we deploy in the culprit lesion, and the last stent in the mid. So in this case, we can have some learning point. The order of stenting in the tortuous lesion. Sometimes we must stent in the proximal segment first. And the case number 4. I think I enough the time. The case number 4. The same situation, inferior STEMI, a very tortuous coronary artery disease. It's the same in the left, no culprit lesion here, and some lesion, moderate lesion in the mid of LAD, but no culprit lesion. The culprit lesion in the right, and can you see it's very tortuous. And we do a wiring, put the wire. And in this case, we use the support from the extension guide, the Zilla. After we do a pre-dilatation, we can see the blood flow. We can see clear the culprit lesion. So we use the Zilla. You see the Zilla to go past the lesion, and we bring stent to the air. We bring stent to the culprit lesion, and we deploy. And then I think the result is good. And the last case, I think very difficult case. The case were referred from the province Kala. The patient with the chest band, a QMI, or maybe a QMI, and were hospitalized to the provincial hospital and provincial cath lab, were done coronary angiogram. And as you see in the left, total occlusion CTO of the LDD, and some lesion in the distal left mat. and the severe tortuous calcified lesion in the proximal, the mid segment of the RCA. And the right coronary artery give the collateral blood flow to the left very abundant. So the doctor, our colleague in the province, to make decision stenting to the left, the right. But because it's very tortuous and very calcified, so they made a stenting the proximal and the proximal part of the mid RCA. And this is the result. So I think the proximal segment and the mid segment, proximal mid segment of the RCA is okay, but the mid and the second curve is still severe. The patient still a check band. And the patient go to refer to our hospital. In our hospital, do we go to the left coronary artery to open, or we continue to the right? And when we check the right, we can see the collateral to the left abundant very much. So I think the complete lesion met the symptom and sign off because the right. So we try to do something in the right coronary artery. Of course, it's very difficult because it's the very tortuous and it have a proximal stand already. So we must go over the stand to the distal, mid and distal of RCA. So of course we use ambulance and 2Y, put Y, and we use the Gidasla from the beginning. But because the guiding catheter not go action to the ostium of the RCA, we must use one or more support from eastern guide or Gidasla. And with the support from Amplas and Gidasla, we can deliver to balloon to the lesion and do pre-dilatation and bring deliver to the first stand to the distal segment and the second stand to the mid segment of the RCA. A little bit difficult. And need the last result. And I think that the distal stand a little bit less, but I think it's okay because in this time we don't dare to push the distal distally the stand because I'm afraid after we do the first stand, the second stand cannot over the curve. So we must put back a little bit the stand so you can see the lesion remaining reason. But I think the collateral blood flow improved very excellent. So that's her message. Small vessel and long diffuse lesion, I have already talked in the beginning. It really challenging for the cardiac interventionist. They easily induce the recession, rupture, long stand within the short term, in the long term, the clinical outcome is very not worse. Stent failure, repeat revascularization is very high, and the most challenge for not only for interventional cardiologist but also cardiac surgeon. Tortuous or very tortuous lesion is the same situation. It may be alone, but it often associates with the small diffuse, long diffuse calcified lesion. It belongs to chip. It means the complex PCI. And the elderly patient is more risk factor for most complex this time lesion. And cardiac interventionist should recognize this type of the complex, and we must predict the complication in PCI to them, and we must know how to manage this lesion and how to manage the complication or obstacle related to this type of lesion. Thank you so much. And I'd like to hear the opinion or a comment from panelists. Thank you so much.
Thank you very much, Professor Hồ Tường Dũng, for a series of very complex PCI in small vessel tortuous. So every complicated PCI that we have to face in our daily practice. So we have 10 minutes for discussing the 5 cases that you presented. So first of all, I want to hear from Dr. Faisal. Do you have any idea of the cases that was presented by Professor Dũng?
Yeah, very nice cases and very tough cases, but very elegantly handled. I think the professor showed many cases where you cannot advance an IBUS, you cannot advance. You don't have the luxury of using all the devices that are available in the market. But I think given those limitations, very elegantly showed how to use support. For example, this last RCA case, using an aggressive, guide that provided adequate support, buddy wiring, and a very tortuous calcified lesion. So I think, a great learning experience and demonstration of many of the techniques that are available. So I think very nicely done. I don't have any question right now, but I'd like to hear what others have to say.
Thank you very much. I only see Dr. Michael Lee is online now. So good afternoon, good evening, Dr. Michael Lee. So
hi.
Okay. So Michael, do you have any comments for the cases was presented by Professor Dũng?
Yeah, I think first of all, greetings from Los Angeles. It's good to see everybody, and I'd like to thank everybody, including Todd, for inviting me. Yeah, I think in daily practice, this really is representative of what we face and we treat. These right coronaries are not the usual semicircles. These are sigmoid shaped, shepherd's crook. So this guideline or Guidezilla has been such a boon for us. I remember we'd have to switch out and take a 8 French guide, but this guide extension catheter has just been such a big bonus for us. I just cannot imagine the days without it. So just when it's appropriate, it's just a game changer. It's really a disruptor in our field of interventional cardiology. So it's great to see those cases being done. And I think this session is kind of exemplary of what that device can do to help the success of these interventions.
So Michael, you just mentioned about supportive guide like Guidezilla. So do you think that there's any difference in between different types of supportive guide like GuideLiner, Guidezilla, or anything else? Because we have so many devices now. So any difference in daily use of it?
Yeah, I was going to address this in my discussion, but just to get to your question, the GuideLiner is a little more flexible. So when you need that extension catheter to, let's say, traverse a sigmoid shaped RCA, or for that circumflex, which comes off at a 90-degree angle off the left main, it is more flexible. Whereas the Guidezilla, it's generally more pushable. It's more stiff and firm. So situations where, let's say, it's a LAD and it's straight, but it's calcified, and especially those elderly patients that have a large aortic annulus, and let's say an EBU 375 or longer needs to be used. I think those cases where there's not a lot of tortuosity but more straighter, I tend to use a Guidezilla for those cases. So again, GuideLiner more flexible, and Guidezilla more pushable.
Thank you, Michael. So I want to hear the opinions from Dr. Vũ regarding the imaging technique for small vessel. So in the first case, Professor Dũng showed a case that's cannot doing OCT for left main LED and also left circumflex. Do you have any idea IVUS can help in those cases? Can we use IVUS to define the diameter, the real diameter of left main LED and also the anatomy of the bifurcations of left main diagonal, LED diagonal and left main left circumflex?
Yeah, thank you, Dr. Hui, for your mention about the IVUS. I think in real life, we have a lot of patients with diffuse lesion, calcified lesion, and long lesion, and triple vessel disease. And when we talk about the CABG surgery to the patient, my patient usually refuse CABG surgery. They usually want to get the minimal invasive procedure, for example, the PCI. So I have some case like Professor Dũng presented here, that the patient don't want to get the open heart surgery. So that's a problem. So when we do the case with the calcified lesion, long lesion, small vessel, and triple vessel disease, usually we use the IVUS to get the optimal result for the case. And is your question about the IVUS? I think the first presentation from Dr. Latif tell us about the definition of the small vessel depending on IVUS measurement. So I think the IVUS very useful for the case, especially for the long lesion. We have some data that long lesion we get the IVUS imaging. We have to get the beta maze with the intravascular imaging, and I think IVUS very useful for the long lesion and also for the calcified lesion and also for the bifurcation lesion. For example, the first case, I think the first case very good candidate for the imaging to guide the intervention, also get the optimal result. Thank you.
Thank you, Dr. Wu. I think that all of you still have questions regarding the cases from Professor Dũng. But anyway, because the program is very long and then there's limitations of time, so I want to move to the next speaker, Dr. Michael Lee from the University of California in Los Angeles. So he's a